Dear Chair, dear audience, let me present you my PhD work, which is the impact of uterine surgeries on clinical and reproductive health. My name is Lőrincz. I'm a medical doctor and a PhD student at the Department of Obstetrics and Gynecology at Semmelweis University. My vision are women without postoperative complications after uterine surgery, and my mission is to find uterine surgical techniques with the least amount of complications. To achieve my mission, I have two ongoing projects, and both of them are conducted with the methodology of systematic review and meta-analysis. My first project is investigating the efficacy and safety of different caesarean section layering techniques. We know that caesarean section rate continues to rise globally, right now accounting for more than 1 in 5 of all childbirths. And we know that in Europe, every 4 children is born thanks to caesarean section. We also know that it is estimated that by 2030, nearly a third of all births will take place via caesarean section. Although caesarean section means safe delivery in many cases, it still carries a risk of short and long-term complications. One specific pathology associated with caesarean delivery is a caesarean scar defect, which is an underestimated pathology due to the unawareness of many clinicians. But we know that in reality, it can be detected in more than 50% of women with a history of caesarean delivery. And it can have many potential complications ranging from infertility to placenta accreta spectrum disorders, placenta previa, scar ectopic pregnancy, and uterine dehiscence or rupture. Single or double layer closure, it remains a topic of debate due to the fact that clinical outcomes are lacking. Our aim is to compare different layering techniques and assess the complications in post-C-section women. So our clinical question is, does double-layer caesarean section closure technique result in a lower incidence of complications compared to single-layer closure? To answer our question, we used the PICO framework. The population were post-caesarean section women divided into 2 categories, with a subsequent pregnancy and without a pregnancy. We compared the double-layer closure with the single-layer closure, and as outcomes, we had complications such as the presence of the scar defect, uterine rupture, uterine dehiscence, and maternal infectious morbidity. We hypothesized that double-layer technique results in a lower incidence of complications compared with single-layer technique. We conducted our systematic search in these 3 main databases with the following search key, which consisted of 2 domains. The first one refers to the caesarean section itself, and the second one to the sutures. With this search key, the search key resulted in more than 9,000 results. And after the full text selection, we were left with 35 full texts. So our first figure is the caesarean scar defect at the 6 weeks follow-up. We compared the double-layer closure with the single-layer closure, and we made subgroups based on whether they used logged or unlocked sutures. We use odds ratio as an effective measure, and the pooled data is 0.59, which means that it is slightly more common in the single-layer closure, but not in a clinically relevant way. Our next outcome is the scar defect at a longer follow-up from 6 to 24 months. And here we see that the odds ratio was 0.67, which means that, again, it is more common in the single-layer closure, but we don't see a tendency in the subgroups either, so we can't say that it is clinically relevant. We say that it's clinically irrelevant. We also looked at uterine dehiscence, and we see that the odds ratio is 0.55, which means that it is more common in the single layer closure. And we also see a tendency, the same kind of tendency in the subgroups, so we can say that it is clinically relevant without reaching statistical significance due to the low patient numbers. And the last outcome, which I will be presenting today, is the uterine rupture. And we see a high heterogeneity here and an odds ratio of 0.62, which means that it is more common in the single layer closure, not in a clinically relevant way, nor in a statistically significant way. But in the subgroup where they used log sutures, we see that it is statistically significant and clinically relevant. So our study has strengths and limitations. We used RCTs, which is the highest level of evidence, and we have a high patient number and, of course, a rigorous methodology. Our limitations are the high heterogeneity. So in conclusion, double-layer suture decreases the risk of uterine dehiscence and rupture in subsequent pregnancies. And as an implication for practice, we would advise surgeons to use the double-layer technique, providing a safer condition for subsequent pregnancies. As an implication for research, we can say that we need more RCTs and cohort studies with different kind of subgroups based on parity and the number of previous cesarean sections. Here you can see the status of our manuscript. Right now I am working on the supplementary material, and this is our target journal. My second project is comparing pregnancy rate after laparoscopic and open myomectomy. Approximately 70% of women develop one or more fibroids by the time they reach the age of 50. And fibroids have been linked to both infertility and recurrent pregnancy loss. And we know that submucosal and intramural fibroids above a certain size are the types that influence fertility the most. Compared with traditional laparotomy, laparoscopy has several advantages like reduced hospital stays, less peritoneal trauma, which can result in a decreased adhesion formation. And our aim is to compare the safety and efficacy of laparoscopic myomectomy with laparotomy and to determine their effect on pregnancy rate after surgery. So our clinical question is, does double laparoscopic myomectomy result in a higher pregnancy rate compared to open myomectomy? As a population, we had women with fibroids, and we compared the laparoscopic myomectomy with the open myomectomy, and our outcome is the rate of pregnancy success after the operation. And we hypothesized that pregnancy rate after laparoscopic myomectomy is higher than after open myomectomy. And as a clinical implication, we would like to help clinicians in the personalized decision making. Here you can see our preliminary search key, which consists of two domains. The first one refers to the fibroid itself, and the second one to the technique, the laparoscopic or open myomectomy. And here you can see our preliminary searches. So in summary, I would like to say that I have two ongoing projects which I plan to submit by September and December this year. And I would like to thank you for your attention with the words of Thomas Berger: "The art and science of asking questions is the source of all knowledge." Thank you.
Thank you for a nice presentation. I would ask regarding to your first project that in Hungary, which technique is used more frequently, a double layer or single layer technique?
So to my knowledge, they use the single layer technique more frequently, although it can vary from surgeon to surgeon and from clinic to clinic, so there is no consensus. Yeah.
Okay. Thank you.
Your first project, did they mention the expertise of the gynecologist who made the cesarean section? It was balanced, you know, so to the residents, how many years of expertise?
Well,
or didn't they mention it?
Specifically, they didn't mention.
Because it can highly
yeah.
affect the outcomes of an operation.
In some studies, they say that an expert in this kind of operation with a few years of experience performed the surgery, but not in every case. So
anyway, you should mention it in your article if they doesn't mention it, because it has an effect. Thanks.
Thank you.
Congratulations.
Thank you.
In your first project, you experienced quite a high heterogeneity.
Yeah.
It indicates that there are more factors, like confounding factors.
Yeah.
Have you identified some that could help, or you have to mention in your limitations?
Yeah. So in some of the cases, this is the first delivery of, I mean, some mothers are nulliparous or primiparous. And another thing in the scar defect formation is that in some of the cases they only used transvaginal ultrasound to identify the scar defects. In other cases they also used saline infusion sonohysterography to identify the scar defects. And I also saw some with only transabdominal ultrasonography, so this can yeah.
Thank you.
Thank you.
Thank you for the presentation. Actually, in my experience as a practicing gynecologist, first they were trying to convince us about the technique of the double layer suture, that it's much better, after that the single layer suture is much better. So I'm really interested about seeing the results again, that after all the double layer, which is gonna be better. Actually, there are some old doctors who are convinced that that's absolutely the gold standard of the suture. But still, I have questions about the outcome. In your first study, you said that at the 6 weeks checkup, you were checking the dehiscency of the uterus, and I wanted to ask you, how did they do that in these studies? I mean, it was a transvaginal ultrasound or transabdominal ultrasound, and what was the definition of the uterine scar deficiency, or how did it?
Yeah, so the 6 weeks follow-up at the cesarean scar defect. Yeah, so they used, in this case, they used transabdominal ultrasound and also, I guess, transvaginal ultrasound in some cases.
And it was well defined what was because, you know, like at the 6 weeks follow-up, you can see sometimes that the scar is not perfectly ready yet, or how is it defined, whether it's already
Yeah, so this also varies a lot. Sometimes, so this can be a cause of the heterogeneity also. For me, it wasn't so clear. I mean, they only mentioned in the studies that a defect of at least 2 millimeters was the definition for the scar defect. But yeah, this can vary from the 6 weeks follow-up up until the 24 months. So
it was also including the niche, these studies?
Yes. So I mean, as I looked at the studies, they use cesarean scar defect as a synonym for the niche, for the niches, and also they call it ismocele in some cases. So, yeah.
Thank you. And also for the second project, it's also about the outcome. And you say that successful pregnancies, how do you define that? It's like pregnancies which happen, patients who conceived, or babies who are also born and healthy, or what was your definition here?
Yeah, so pregnancies which lead to babies being born, I guess.
Thank you very much.
Thank you. I only have one question regarding your second project. So you're comparing the laparoscopic and the open myomectomy for patients with fibroids. Is like, whose decision is that? Is it like the patient factor who decide the type of surgery, or the doctor?
So in the fortunate cases, the doctor decides which way is to go. So yeah, but there are cases in which laparoscopy isn't an option.
Yes.
So if you have a huge myoma, for example, it can be hard to perform laparoscopic myomectomy.
So you are including two-arm studies that directly comparing the laparotomy to, yeah.
Exactly.
Okay, thank you.